part of this session, which is a panel discussion. Yeah, she will be the moderator. Dr. Shweta is the moderator, and the speakers. So what are the tables? Okay. Okay. So the speakers are Dr. Ganpati Bantwal. He's from Bangalore. Welcome. He, of course, is a well-known thing. He's been a past president of our Endocrine Society. And, of course, you can read out whatever it is, and that's it. And then we have Dr. Sagarika Mukherjee. She's from Kolkata. Okay, so Bengaluru and Kolkata. Better pronounce well. They'll start calling Mumbai Bombay. And then Dr. Hia. She's from Haryana. She's a consultant endocrinologist in the north. So now we have speaker from the, it's an all India phenomenon. So we are seeing a speaker from south, east, and the north, and the moderator is from the west, because we have to moderate the western influence which is causing all these problems. Okay, over to you, Dr. Shweta.
Will require mics. Do you want to sit here, Shweta? I can sit. Thank you. So, good afternoon, everyone. At the outset, I would like to welcome you all again, and it's a pleasure to be part of this panel here. We have very renowned and elite endocrinologists here to discuss with us about the problems related to substance abuse in adolescents and young adults. So when I was a DM endocrinology trainee, I used to think that it's really a Western problem and sort of exam problem. I need to read it for exam and then forget about it. But over last 1 decade, it has become more of a clinical problem for us. We do see like 3 to 4 patients every month who are on this performance enhancing drugs or other who are using other substances. And from endocrine perspective, it's also the use of anabolic steroids, growth hormone, these which cause more of problems. And though the patients do not come up directly with the history that they are using these substances, oftentimes we suspect it based on their clinical presentation. So to answer all our queries and to throw more light about the problems related to substance abuse, how to evaluate these patients, when to suspect that the patient may be using substances, and how to treat this is really a clinical challenge, and we have our eminent faculty here to discuss about these things. So my first question is to Dr. Ganpati. As earlier we used to think that this is like more of problem of USA, where almost 70% of the adolescents use substances. They start using it from adolescence itself. But gradually I think even India is at the brink of substance abuse crisis. So what sort of epidemiological data or problem statement do we have for India, sir?
First let me thank the chairpersons and Dr. Sheila for the invite. As you rightly told, there's a national survey was actually done on this, and they found that the prevalence of substance abuse of alcohol is around 20%, smoking around 30%, and cannabis around, say, 3%, and opioids around 0.7%. Then the Ministry of Social Justice, they submitted one report telling that approximately 15 million children, adolescents, between 10 to 17 are actually having substance abuse. And if you see the overall thing, around, I think, 70 lakh people have are having substance abuse on cannabis, 60 million on opiates, 16 crore people using, this is overall data given, using alcohol, and out of which around 4 crore, I think, are having dependence. So this is the frequency of, or the epidemiological data on substance abuse, yeah.
I think that's like a huge problem. We have like millions of people who are abusing the drugs right now in India. And I think the northern states are facing a lot of problem.
So among the states, yeah, right, UP followed by Punjab, and then Sikkim, Delhi is around 18%, Manipur, Meghalaya around 12%. That's what they think. It could be more also because the survey is a little bit skewed sometimes.
Right. So do we have any data about the anabolic steroids as well, sir? Anabolic steroids.
No, that data, I mean the overall, yes.
But, right. So maybe if we survey the gyms or bodybuilders, maybe 80% of them might be using it, is what it looks like. So it's very common.
80% mat bolo, please. Don't
It's
frighten us.
data from one of the surveys, sir. 70 out of 89 people, bodybuilders, were questioned in one of the India's smart city, and they were using anabolics. So what we get is like just a tip of iceberg in our clinic. Probably less than 0.1% report to us, only when they get into problem, when they get married or they have infertility or problems related to erection, probably. So my next question is to Dr. Sagarika Mukherjee. So, madam, when would you suspect that your patient may be abusing these anabolic steroids, performance-enhancing drugs, or any sort of substance? When do you think of, administering some sort of systematic, questionnaire or?
Now, these substances, as you mentioned just now, that anabolic steroids, these are used off-label without any prescriptions, and these are usually procured by the person who wants to take them or someone whom they think is quite superior to them, and prescribing either getting from like traffickers or getting some unsolicited sources. So this is the way that they procure it. Now, adolescent, maybe boys in the late teens are very much prone that they should look good, they should look nice and be appealing. And by the way of it, going to the gym, making them feel nice or feel good, having to say that they have gained a lot of physical strength and physical power, they might fall prey to taking anabolic steroids. Its first kicks off by taking some oral anabolic steroids, which they may not know what the composition is. It might be some sort of synthetic testosterone derivatives of any kind. And when they feel the kick of it, then with further peer pressure and further pressure from the gym instructor that your muscles are really not going that much, you're not gaining so much of strength, they might go into injecting therapies as well. Now, when you say anabolic steroids, or anabolic androgens rather, what we call anabolic is something which will help you to build up your muscles. And androgenic means it will help you to virilize as well, so that you have your macho male-like features. But along with androgens, they also inject other stuffs as well, which may consist of a cocktail of growth hormones, steroids, sometimes some anti-estrogens as well, to counteract the effects of androgens. So whenever they're coming to you, and say for after some time they just stop and taking the steroids, they might suffer from withdrawal effects of these steroids. So whenever they come to you for medical help, no one is going to really own up and say, I'm injecting drugs and this is what I have. So you have to really have got a very, very open eye of clinical suspicion to say that, yes, this person is injecting steroids. Some odd form of like behavior, they might be very restless, like manic, bursting into anger, might have unusual acne development, unusual loss of hair, maybe virilizing features even in girls as well. So these are the things that when you will suspect that there might be some story of drugs going on behind, or there might be abnormal abscess formation at injecting sites, undue disruption in their LFTs, maybe undue hypertension without any reason, or some other cardiovascular form of presentation, gynecomastia, etc.
Right. Very nicely brought out the problems that we actually see as symptom complex, and then we kind of suspect whether this patient is using or abusing rather anabolic steroids. So my next question is to Dr. Hia. So as we discussed, like the anabolic steroids are the commonest substances which are of concern, at least to us. So what sort of preparations do these people use off-label, and what's the pattern of use? We actually learn all these things from the bodybuilders only. So
yes, ma'am, thank you for the question. The most commonly used substance for bodybuilders and even in athletics, actually there are 4 types of abusers. One is something which is known as YOLO type. YOLO means you live only once. That is their philosophy, that you live only once. So you have to have all these things so that you look good and your muscle is also grown to develop that macho kind of appearance, as ma'am has already said. Another is this athletic competition. So this abuse in athletics, it started as early as the 1936 Olympic Games. In the 1936 Olympic Games, it is said that even Hitler had given some steroids to the German athletes, but it's not proven. Then during the Cold War, there was a lot of competition between the Western Front and the Soviet Union. So it was said that many of the Soviet players, they were abusing all the steroids. Then one person from the USA, he came to know about this, and he too started the same thing. The same pharmaceutical products were used, and they were first utilized in the basketball players in the United States. And then the International Olympic Committee, they came to know about this, and they then found, they started very stringent laws for controlling this. The most commonly used is testosterone preparation. So there are various forms of testosterone, like testosterone, propionate and enanthate, which are commonly used. Apart from this, there are other substances like nandrolone, oxandrolone, methandione, which are again commonly used anabolic preparations. Then we have other agents like the precursors of testosterone, such as androstenedione and dehydroepiandrosterone, which are again used as precursors to produce testosterone. And some other agents like anti-estrogens, as ma'am had said, are also commonly abused. Like we have the selective estrogen receptor modulators, such as tamoxifen. This is also commonly used. And some other preparations like human chorionic gonadotropin, that is also abused. Then the various forms of abusing are, there is one pattern which is known as cyclical pattern, where the person takes the doses in cycles. That is, he will take for some time, then there will be a gap period, and then he will again start taking the dose. And there is another pattern which is known as stacking. In stacking, he takes all the forms concurrently. Then we have something which is known as pyramiding. Pyramiding means first escalating the dose and then de-escalating the dose. And then there is one more pattern which is known as bridging, where there is no gap, and the person again alters the doses in between, but he doesn't stop it completely. So these are some of the patterns how this drug is taken.
Right. So it's all a cocktail. There was a statement in one of the articles, like practically all the anabolic steroids which are manufactured or developed for human or human use or veterinary purpose have been abused so far by the bodybuilders all over the world. To counteract the side effects, they use HCG, and sometimes they use these serums to prevent gynecomastia. So all sorts of problems the patients may have, and as a result, you may have very different kind of biochemistry based on when they have injected and how much they have been taking. And most of the times they take supraphysiological doses rather than what we prescribe to our patients as a replacement dose. So what I have heard from my patient is like they take around 300 milligrams per week of testosterone. Then cycle it with HCG. Sometimes they come to us with history of anabolic steroids openly, and now they've developed hypogonadism just to take the prescriptions of HCG and then just disappear from your follow-ups. So all sorts of things happen. So all these bodybuilders and athletes, they abuse these drugs basically to enhance their muscle strength and the performance. But actually, does it have positive impact on these parameters, sir?
Yeah, I mean, if you see the mechanisms, it's more selective. It acts on the androgen receptors, and also it is having an anti-catabolic effect by blocking the glucocorticoid receptors. So the first, I mean, before we came to know, the athletes came to know that yes, it will actually help, and that's how I think at least we know from Ben Johnson's era. He beat Carl Lewis taking stanozolol. So, and this has been proven actually by Shailendra Basin. So he gave, in fact, high doses, 500 milligrams per week, and over 12 weeks, and they found it did improve the performance in these athletes, especially when you did vigorous exercise and more nutritious diet when you had that, it did improve the performance. So it was proven beyond doubt that it does help when you use it along with these components.
Right, so it does have some impact. Maybe it can bring a person who deserves to be bronze close to gold, but a person who is nowhere, I don't know where he will get with even you abusing all these anabolics. So my question is to Dr. Sagarika now. So all these drug abuse and all going on, like what sort of psychological and physical complications do we come across?
They start taking these drugs or pharmaceutical agents, if you may call them, on volition. It's not on prescription. It comes on prescription whenever you're going to see an endocrinologist, either for hypogonadism or for some other endocrine disorders, and they're given in really what we call as minuscule amount to the amount that they inject. They are injecting in or they're taking it in supraphysiological levels. And as Hira was mentioned, Hia was mentioning that they have got cycles of injecting, and there is no fixed cycle that how they are going to take. The cycle may consist of 6 weeks to about 18 weeks and consist of a cocktail of oral and injecting agents, and injecting agents are also variable. Now, when you're injecting really very strong testosterone, synthetic testosterone derivatives, not only that your muscles are developing with hard exercise, but there are a lot of development of subcutaneous fat as well. Now, fat is not good for any bodybuilder or for anyone who is going to show their muscles. The muscles must look very sleek and thin, and there shouldn't be subcutaneous fat visible. So, in order to take away the subcutaneous fat, there are some testosterone derivatives which do, and subcutaneous fats mainly come from aromatizing effect, and estrogen develops and subcutaneous fat develops from there. There are some testosterone derivatives which do not undergo aromatization, and so estrogen is not converted and they do not develop subcutaneous fat. So these are taken in cycles and they have got various effects. Now, first and foremost, because of aromatization, they have developed gynecomastia, like their body image might get distorted. So in order to curb down gynecomastia, they are taking anti-estrogen like tamoxifen and clomifen to curb down these effects. So they get various signs of burst of acne, increasing body hair, and if they stop taking these, then they feel that their libido is going down, their power is going down, the muscles are slackening. And over a period of time, you feel that drugs which work on the central nervous system, you have a dependence on them. But steroids will not have a dependence. But steroids, each and every cell of our body do have steroid receptors. And if you're taking steroids for a long period of time, they do affect the neurotransmitters in the brain as well. And you develop some sort of dependence, and you develop a habit to procure them, continue to use them despite knowing that they're causing so much of ill effects, because you don't want to lose that kick power within you. So you develop a lot of agitation and mood swings, irritability, not behaving properly, lots of aggression, and lead up to troubles for this.
Right. So a lot of physical complications, psychological complications, occasional polycythemias, accelerated hypertensions. We do come across patients admitted in ICUs with accelerated hypertension, and they've been abusing huge doses of testosterone. So they can come up with a lot of problems. So the commonest clinical scenario that we come across as endocrinologists is that when a person has abused these steroids for a long time, and now they've either got married and they've stopped using and they have problems with their libido, erection, fertility, or they're not married but they want to stop, but they're not able to stop using these anabolics, because as soon as they stop, they develop features of hypogonadism. So how do you treat these patients?
Long-term use of these steroids actually cause suppression of the hypothalamic pituitary gonadal axis, and once the steroids are stopped, the patient may develop hypogonadism and clinical features like loss of libido, erectile dysfunction, and infertility. And this is when they present to the endocrinologist. And as an endocrinologist, it's important to assess whether the axis has recovered or not, and we need to take history, when was the last dose taken, although the person may not reveal, but still it's important to take this history. And we should do basic clinical investigations like luteinizing hormone, FSH, testosterone for males, and for females we should also do estradiol. And generally we should let the access to recover itself. We should not give any injectable medicine at the first go itself, and we should just let the access to recover itself. But sometimes when the patient becomes too concerned, then there are certain agents which can be used to fasten the recovery. For example, clomiphene citrate can be given, and human chorionic gonadotropin in males has also been found to fasten the recovery of the hypothalamic pituitary gonadal axis. So in certain scenarios, it can be provided, and particularly if the patient is concerned with infertility, then as a treatment protocol for infertility, HCG in males along with recombinant FSH can be provided as a therapeutic option.
Right. So the treatment would depend on the duration. So sometimes if they have abused it for a long time and that has led to shrinkage of the testes, the axis may not recover completely at all. So then the patient may have to be on physiological doses for the life. And again, as far as fertility is concerned, we all have been using HCG, but it's like kind of off-label. Again, we don't have data whether giving HCG actually helps recovery of the axis and helps them to have better spermatogenesis and fertility. Sir, as these patients, they come to our clinic and we are the ones who suspect because nobody ever comes with that history written on their forehead. So what are the biochemical clues that you get in these patients when you actually suspect that this person may be abusing the anabolics?
One is you get a testosterone FSH LH. Suppose he's taking exogenous testosterone, the total testosterone will be high, LH FSH will be suppressed. Suppose he's taking a testosterone precursor, that will get converted to testosterone. Once again, the total testosterone is high, and naturally it will suppress the gonadotropins, LH, FSH. If he's taking a non-testosterone anabolic steroid, all the three are low because it will get suppressed. Suppose you are using an aromatase inhibitor, so then what happens is the testosterone is high and the LH, FSH is also high. The same thing with clomiphene also. This is a rough idea clue. Now you want to pick up, is he abusing, then we can actually do testosterone, epitestosterone ratios. The normal is around 1:1. And if it is more than 4:1, suspect he is actually abusing. But there is a problem with that. The reason being in Asians, it is said that they have a gene which actually interferes with this, and that's the reason many times it may even be normal in these type of patients if you are abusing. And that's the reason now they come out for this abuse to pick up is what is known as athlete's biological passport. So that's before, once they enter into these athletes, they'll have to give a sample, urine as well as a blood sample, where they'll measure testosterone precursors, epitestosterone, other precursors. And then the premise is, whatever you do, it'll be the same ratios will be maintained. But there are fallacies of these also. But then this is the latest which is happening for finding that.
Right. That's very interesting. So if we have enough time, can we take one last question? 10 minutes? Okay. So Dr. Sagarika, so when these patients come to us as doctors, what are the legal implications when the patients are using illicit drugs? Are we supposed to report it, or it's, what sort of responsibility do we have?
Difficult to say, because the law hasn't decided whether taking drugs is a disease of the mind or whether this is an offense. Sincerely, when at the time of independence, our constitution was written, and in Article 47, which comes under directive principles of state policy, the constitution endorsed that the state should take care that you are not going to get your citizens involved in drugs and alcohol. And drugs at that point of time meant opioids and cannabis, and which was the only drugs which were available maybe at that point of time. But a lot of water has passed along the Ganges, a lot of new products have come into the market. And so in order to consolidate all of these narcotics, another act came in 1985 called the Narcotics and Psychotropics Drugs Act. And there the rules and regulations are a little bit more stringent, because if you commit any offense under that act, you have a cognizable offense and it's non-bailable. And any directive which has passed or any rule passed under the act, it cannot be refuted or it cannot be changed at all. But again, when a person comes and confides in his doctor, the doctor-patient relationship comes in a fiduciary relationship, and therefore the doctor really cannot reveal all the secrets that the patient is taking in, but it has got a caveat. If the doctor feels that the society as a large is being harmed by the person, and if the person is found out to be a drug trafficker, then his punishments are stringent. But if the person really wants to come off addiction, wants to undergo rehabilitation, then there is law to back him up to come off these problems.
Right. So I think that's like a very good guideline that you have told us. So my last question is to Dr. Hia. So many times, like not many times, at least 3 to 4 times in a year, we get parents who have brought their child who is going into the field of modeling or who is going to be a first-class bodybuilder, and they want to ask us whether these anabolics are safe or not. So how do you counsel these parents? And if someone is already abusing these anabolics, how do you counsel them to help them come off that or refrain them from using it again?
Yes, with the over-increasing competition that is going into society to look good, to develop this particular body, particularly in adolescent age group, there is craving for this. For males, there is craving for this macho type of features, and for females to look like a model. So there is a lot of pressure put upon the adolescent. And so that is why most of these young people, they are vulnerable to falling prey to all this substance abuse. And as clinicians, it's our responsibility to form educational groups and educate the public regarding the various adverse effects of these agents. For this, support groups are very important, not only the doctors, but the community workers and there should be strong peer group as well, and these things need to be communicated via all media platforms, and this needs to be communicated to the young persons, what are the adverse events. There are certain groups also, like the Atlas groups. The full form is, I think, athletic training to avoid steroids for males, for male adolescents, and another is one Athena group for female sports person. This is for athletics. So these two groups particularly work for preventing this performance usage of performance enhancing drugs in this type of population. So it is important to involve the person right from a younger age group, and the people who are involved in sports, particularly the coaches and the other sports personnel. They should also educate the younger upcoming sports persons about the laws of the National Sports of India and Sports Authority of India, and what are the adverse effects and what are the long-term repercussions of this. So only with community support group and contribution of everybody in the society, we can prevent the youngsters from falling prey to this performance enhancing drugs and also to this abuse.
Right, so like just they come to us and we give them in writing 1 to 10 things, right from polycythemia strokes to CA prostate. I don't know how much it really helps them. I think a lot of measures need to be taken at the governmental level, societal levels, so that the patients and their families have access to right kind of information to help them take informed decision about using these drugs or staying away from them. And also the Ministry of Social Justice is taking a big initiative. They had set up this survey which gave us at least some real data about the realities of drug abuse in India. They have also set up Nasha Mukt Bharat Abhiyan, which is going to be rolled out in near future to help the adolescents to stay away from the drug abuse. So I think with this we've finished all the questions to our panelists.
Can we have a question? Can we have a question? When the pituitary adrenal axis is suppressed, or these FSHLH axis, how long does it take to recover? Because I've seen patients 5 and 6 years with no recovery.
Yeah,
So
if you are
how
used
long
it
do we
less
wait?
than 1 year, usually they recover faster. They say by around 3 to 6 months, the gonadotropins start increasing, and by another 6 to 9 months, the testosterone. But if it's more than 1 year, it may take 2-3 years or even more, as you told, 5 to 6 years
Yeah,
also.
5 to 6 years,
Yes,
and there's
it's
no.
possible.
And
It's like steroids only. HP axis suppression depends. Some individuals early, some individuals
So I have a
late.
patient, 3rd year, he has come to me recently. His serum cortisol is still 1.2 microgram. So he's not nowhere near the
Yes.
recovery. And he went into an adrenal crisis. That's how we found out and started treating and all that. And there doesn't seem to be in 3 years and 4 years, the patients get jittery, you know.
Yeah.
And it also depends upon the length of the long chain fatty acid which is attached with the testosterone, because longer the chain, the more prolonged it stays within your body and takes
That
time
is
to get
something
away.
history we don't get. He says, somebody gave me and I took it, you know. You just don't know what kind of preparation sometimes they have taken. Usha.
Thank you for a great panel, and I have one question, and it's to lead off from what he has said about female athletes. So, or not even athletes, women who are now, want to do that kind of a sculpted body, and so what's happening with them, and are you seeing that, and what kind of problems are they coming with, and how should we counsel them? And we can also talk about the other thing, which is smoking among women, and they think vaping is safe, the e-cigarettes, and what kind of harm are we seeing with that?
Of course, the females are also taking, and they do take anabolic steroids as well, but not to that extent as their male counterparts. And in order to reduce the virilizing side effects, they take various sort of estrogen-like products or estrogen products which mimic or like estrogen and bind with the estrogen receptor, so that virilizing effects might not be as much. And of course, smoking is also increasing, and within the cigarette there is just not the tobacco in it, but there are other products which are coming along. And initially when they start off doing this, either by peer pressure or thinking that it's being very modern or up to the keeping up with the generation if they do this, and then they continue that until they really reach that enlightenment state, and after that all these side effects start developing, and then you tend to see your patients and who are really faced with all these side effects, and like cardiovascular disease, reduced fertility, a lot of mood swings, mood disorders, psychological disorders, etc. Do you want to add?
One problem is the voice can change, so that's the reason many don't prefer to use this. So that's because once it changes, it's very difficult to bring it back. So that's the reason we don't find so much. Exceptions will be there, athletes, the female athletes. So this is one major problem. Acne, etc., yeah, those things, clitoromegaly, these things can happen, and she told.
Often what happens just prior to the sport, say if you have got a major event lined up in 6 months' time, maybe for 6 months or 3 months prior to the event, they might take small dosage, but not for a prolonged period of time like males do.
Yeah, I have one question. See, we spoke about the anabolic steroids, but then recently we had seen a lot of these bodybuilders are taking growth hormone and something called as growth hormone receptor analog. I tried to search it, but then we don't know from where to procure it. These people know from where to procure it. So what is it, and what are its long-term effects?
So the use of growth hormone dates back to the 1980s when one American boxer, he wrote a book about this, and recently there are various preparations of, like, as you have mentioned, growth hormone receptor analog, IGF-1, growth hormone. Although IGF-1, it is very difficult to procure for us, but these people are procuring this from somewhere. Even from the state where I am practicing, that is Haryana, there is again a lot of people are using this. The long-term effects, in the literature it shows that growth hormone over a short period of time increases the synthesis of protein in the body and increases the synthesis of both type 1 and type 2 muscle fibers. It increases the exercise capacity of the athlete, and it also increases the ventilatory oxygen capacity. But all these are short-term. Again, there is no data what are the overall long-term effects of this medicine.
No, growth hormone receptor analog, I tried to search in the literature. Nowhere it is mentioned that it's like IGF-1. It is something different. I don't know what's it. Everywhere it's mentioned only growth hormone receptor analog only. I don't know what's it.
Like in Western countries, they use both HCG as well as human growth hormone as well as IGF-1. But here our patients don't get, so it's the. I don't think the people have access to IGF-1 here.
Okay.
So I think every drug that comes in and has some miraculous effects is likely to be abused by the population now. Like we have semaglutide, which is being abused by the celebrities. So I think we've finished our panel discussion, and
Yes.
thank you, chairpersons, and thank you,
Thank
the
you
panelists.
all of you. Very well moderated also. Sweta, sorry, not Shweta, Sweta. And this is one place where women's equality, thank God, doesn't exist. And otherwise we try for it. And one thing which I wanted to just joke at the end, that some patients who have alcohol or tobacco-induced health complication, they ask, doctor, can I smoke, can I drink? So my standard answer is simple, that you can smoke on 30th February and drink on 29th February. Thank you.
Thank you all very much, and thank you the organizers for inviting me for this beautiful session, and we finish it here.
Well, the only thing I can say today is that I am so glad I finished my adolescence. I dread and shudder to think what these girls today are going through. Not only the definition of PCOD has not changed, and we really did not think, if you consider the previous generation, our mothers and grandmothers, for them there was no PCOD. There was something which was okay, menses are irregular, ho jayega, bachcha ho jayega, and that was the end of it. When it came to our generation, you and me, it was a little beyond menstrual irregularities, maybe skin related issues. And now what we are dealing with is about what everybody has talked about this afternoon, that it's no longer menstrual problems. There's an increasing incidence of obesity, which is a big, big problem. And this is not only important in the higher strata or the higher middle class, but even the lower strata of society, the girls, their parents, girls who don't listen to their parents, of course, are fighting with. Nobody had heard of type 2 diabetes occurring at such a young age. At this young age, it was only type 1, perhaps heard about it, but not really encountered it. But today we know that these young girls, thin or otherwise, have an increasing incidence of type 2 diabetes. And today, as Dr. Belinda told us, that it's not only type 2 diabetes, but we have to think of complications. I think the gynecologists, the endocrinologists, the government at large has to bring to everybody's notice that it's not only obesity, but the complications that these girls are going to have. And the panelists very nicely told us a lot about substance abuse, the incidences, the way it's raging forward, and it's going to ultimately cause a big problem. Let me tell you, this is just a tip of the iceberg. I don't know much, I learned a lot. But most of the parents today don't even know what their children are doing, males as well as females. मेरी लड़की बहुत अच्छी है, ये कर ही नहीं सकती है. I cannot imagine. This is something that we don't have to believe, because we really don't know what's happening. I had a wonderful time this afternoon, the first session of We Care, where fortunately we talked about these young girls, and I'm sure it's going to be another good session where we are going to talk about bone health and women. Thank you so much.
Thank you, ma'am. Thank you to all the speakers. Thank you to the chairpersons for the insights. And I would request all the faculty to meet at the felicitation point for felicitation and a photo.